Okay, so this is just the resuscitative thoracotomy station, and what I want to cover is the goal. This is the goal. You know, the goals of this thing are to the indications and survival rates, basically. The goals of what they're actually doing once they decide to do a thoracotomy, what they're trying to achieve, the nurse's role, and then just some miscellaneous things that they wanted us to go over. So I met with Dr. Kim and Dr. Costantini and just kind of went over what they wanted us to be doing and what they wanted us to know about it. So this is just some stuff that I put together. There's this kind of study, if you ever want to read it, it's pretty interesting. It's this Ree et al. It was a study done in 2000 that they looked at like the past 25 years of, you know, it was like 65,000 thoracotomies, and basically gathered data from based on those and basically try to determine what determines whether you're going to survive or not and who does survive a thoracotomy. So they call it an EDT in most of the literature, so that's what I called it. But an EDT is defined as a procedure that's emergent and performed in the emergency room or trauma room shortly after the presentation of the patient. The indication, so basically who's going to get it. Mm-hmm. The most accepted factors taken into account determining whether someone's going to get a thoracotomy are the mechanism of injury. So of course for us we're looking at stab wounds, gunshot wounds, and then blunt trauma. And then the location of the, you guys are killing me. Okay, the location of the major injury. So where is it? Is it the chest? Is it the abdomen? Is it multiple places? And then also signs of life. So, you know, presence or lack thereof of signs of life. And they define those as cardiac electrical activity. So they don't, you know, they didn't really specify a pulse or not, but if you have some cardiac electricity, that's a sign of electrical activity, sign of life. And then respiratory effort and pupillary response. So in the literature, the overall survival rate was 7.4%. This is, you know, just the overall, when you average all the survival rates together, you know, blunt traumas with no signs of life, it was like 0.03%, and then some of the really, you know, higher percentage were like stab wounds directly to the chest had like as high as a 19% survival rate. So anyway, the average was 7.4%, which 92.4 of those survivors, you know, having a normal neurological exam afterwards. So that's, you know, it seems like once, if you do survive it, you survive it pretty well, or you don't survive it. So the mechanisms of injury, the penetrating trauma survival rate was 8.8. So with the stab wounds as high as 16.8, and then the gunshot wounds a little bit lower at 4.3. So that's, you know, believed to be with all the trajectory of the bullets causes, you know, more damage than the force of just a single stab or multiple stab wounds even. And then blunt trauma was 1.4%, which is the lowest. On the location of the mechanism of injury, so thoracic injuries had a higher survival rate than abdominal injuries. Predominantly cardiac, those survival rates were as high as 19.4. So the best thing would be to be, you know, stabbed directly in the heart. Your chances of survival are better than anything else. Abdominal injuries, 4.5%, and then multiple injuries was 0.7%. And then the signs of life in the hospital, someone that came in with signs of life and then lost them were 11.5. People that had signs of life in the field but none by the time they got to the hospital were 2.6, and then patients that had none signs of life were 1.2%, which most of this were actually lower than that, but there was a few that had some really high, you know, 6% survival rate, so it kind of raised that overall statistic. But anyway, in summary, the mechanism of injury, location of injury, and signs of life are key factors that influence the result of an EDT. And the best survival rates reported were stab wounds and thoracic and predominantly cardiac with a sign of life in the hospital. So for this facility, from what I can, you know, there's not a real clear algorithm on the website. You know, there is for a penetrating chest trauma. Basically, if they're stable, they, you know, might do an echo or a transthoracic echo or a esophagram, and then they're going to go to the operating room. If they're unstable, they're going to do a thoracotomy. Basically, was that. But as far as blunt trauma, there's not a real, you know, there's unstable patient, and then there's either OR, thoracotomy kind of choices. But the general indications for an EDT would be patients with penetrating thoracic injuries with a sign of life in the field, at least, and who do not respond to fluids and are losing their vital signs in the resuscitation room. Now this is in lieu, you know, if they're sort of, I asked Dr. Costantini if they're kind of, you know, maintaining a blood pressure of 60 and they're sort of maintaining, you know, ultimately your goal is to get them to the operating room. So if you feel like if they feel like they have time to get to the operating room, that's what they'll do. Otherwise, they're going to do thoracotomy here. And then the relative indications would be patients with penetrating abdominal injury with at least one clear sign of life in the field. And blunt trauma, patients who lose a sign of life in the hospital or immediately before arrival. because with the blunt trauma, basically you're just putting a tourniquet. You're assuming that they're bleeding from below the aorta here, so you're just basically putting a tourniquet on it and trying to stop that hemorrhage till you can get control of the situation. So ideally they need an X-lap, so you're not going to do an X-lap here in the trauma room, so you're going to do a thoracotomy to hopefully bridge the gap to where you can get to the operating room and do an X-lap. And then contraindications for patients without any signs of life in the field from either penetrating or blunt trauma. So if there's never reported a sign of life, they're probably not going to do it. Although, Todd said if it was, if it happened right here on First Avenue and they got here really quickly, you might do it. If they've had CPR with no signs of life for 15 minutes, then you're not going to do it. So that might be a judgment base. And I would also probably think that we probably as a teaching facility would do it more than a non-teaching hospital. But can always be prepared, right? And then I said, well, why not do it on everybody? What's, if they might have a 1% chance of survival, but they just said, it was important to identify who's going to benefit from it because, it's a valuable use of resources for a couple hours. Probably there's going to be, this room is going to be tied up. There's going to be a lot of people. It's a high cost, even if they do survive, maybe to get to the ICU and spend a couple days in the ICU and then ultimately die anyway. So they're just trying to figure out, do it on the best people that's going to have the best chance. And then the risk to healthcare personnel, they both talked about that as far as, that's when people get splashed and stuck in emergency situations like that. And then there's just, there's been documented low success rates under, specific populations, predominantly people with blunt trauma who don't have any signs of life. Todd talked about to me for a penetrating trauma, they want to be sure and visualize, do a quick 2-second look of the entire body because you don't want to, open someone's chest and they have like a gunshot wound right to the spine in the middle of the back, and that's the problem. So they, as soon as you get them in the door, you want to start initiating exposure, and you're just going to do a quick 2-second look at the back. And the surgeons are basically just trying to guess, where the hemorrhage is coming from. Should we start here, here, or here, basically? So you also want to make a quick note maybe that they're moving all 4 extremities if they're, awake and able to do that. So again, you don't want it to be like a, gunshot wound right to the back of the neck, and the reason they don't have any blood pressure is because they're in spinal shock or something like that. So the procedure is going to be, they're going to rapidly open the left anterior chest between the 4th and 5th intercostal space, and also, securing at the same time or prior to this, they should have a secure airway. And, they both thought that one really good working IV is good. They don't want to delay it to get that second IV. But, you're going to have your left arm up. So, if you've got an AC here, it might be good to go ahead and try to work on getting one in the right hand that you can kind of get access to and control better. And then also, especially if it's a blunt chest, they're going to simultaneously probably be putting in a chest tube in the right because you're going to rule out that maybe they have a tension pneumo or something going on that right side. So probably simultaneously someone's going to be putting in a right chest tube. So once they do open the chest, the goals of what they're trying to do is to control hemorrhage. And they can do that either with, just putting a hand on what's bleeding or cross-clamping the aorta, of course. And then a pericardomy to relieve the tamponade and control a cardiac hemorrhage. So when they go in there, they can quickly visualize if the pericardium is bulging, then they can, open it up and see what's bleeding in the heart and relieve that pressure. And then cross-clamping of this descending thoracic aorta to increase perfusion to the heart and possibly decrease the distal hemorrhage. So I've always, heard this cross-clamping in the aorta, but I was like, what are you doing? And all they're doing is just trying to, if you're bleeding from below, they're just putting a tourniquet on it here. So I know Dr. Kobayashi did one within the last year or so that was a bad pelvic fracture that was hemorrhaging. And so she did a, did that person survive thoracotomy?
No, did not survive. She was telling us the cross-clamping and all of those, and
I see.
And pressure, we never really get a good pressure in the patient.
Yeah.
So
did that patient come in with vital signs? Do you remember?
Yeah, actually.
Yeah.
We ended up the CPR in Bay 2, and then we ended up doing everything here. And then doing to the OR.
I see. And then they died in the OR?
They died in the OR 4 hours later.
And Todd was showing me, this was a good picture of he was just showing me once they open the chest and they lift the lung up anteriorly, the aorta is really easy for them to visualize right there. So it's not that, it's a good, easy access to the aorta. And then also open cardiac massage. So there's lots of studies that show that CPR on a trauma patient with nothing in the heart is basically useless. So, you're determining if there is any, if they do have lots of blood volume, and then you're fill it up, and you can do open cardiac massage, and also with internal defibrillation if we need be. And then also cross-clamping of the pulmonary hilum when indicated to control air embolus. So this one I wasn't clear about. So Dennis drew me this picture and I tried to recreate it, and my heart looks like a strawberry, I know, but anyway. He was just showing me, this is, the right main stem. And then basically the pulmonary artery and the pulmonary vein are right here by the bronchus. So the pulmonary vein, is carrying oxygenated blood directly to the heart. So if you have some kind of injury right here to the bronchus, it's really easy for big air boluses to go directly into the heart and basically kill them. So they'll just clamp off that whole area to prevent that from happening. And then, okay, for us, the nurse's role while this is going on, obviously they're going to do a quick prep. So we want betadines and 4x4s just to do a quick prep to that left side of the chest. They want to get, personal protective equipment for everybody, which we have it over there. It might be kind of pass it out real quick to everybody, definitely goggles and gloves and gowns and hats and all that. We want to have a thoracotomy to the left side of the bed, so our thoracotomy tray is over there in that C locker. And
excuse me, Tanya, do we still have the differentiation between the sternotomy tray and the open chest tray? Because for this, you need an open chest.
Open tray, yeah. So this one, both of them back here are open chest tray. Yeah. So I don't think there's not a sternotomy ones in the unit. So both these back here are open chest.
Yeah. Correct.
Yeah. And then, the blade that they're going to use to open the chest is this 10 blade is what they want. So, and they're taped on the outside, which is always a problem when they open it up. A lot of times it goes on the floor, nobody can find it. So we do have, all the bedsides have 10 blades here. So you can always, if they can't find one, get it extra. We have 15 blades here, which those are for trachs and crikes. And you can tell if you look at them, that that one's like a little point for the trach and crike, and this one is like a regular, looks like a butter knife kind of handle. So anyway, the 10, if else, just grab a 10 blade that they can use for the skin. And then, like I said, again, they're probably going to be putting in a chest tube on the right side. So you want to go ahead and kind of get that prepared. Overhead lights is good. We have one over there, and then there's one over here too. And then get suction ready for when they go in there, sterile suction preferably. And then the defibrillator with the internal paddles, and then 15 to 30 joules is kind of the range, although I think Laura said some doctors might start at 10, but anyway, that's the normal value that you shock someone at. And then you want to request emergency blood and have the level 1 if that's what need be. Now they did talk about, there's now, especially with penetrating and that whole idea of like giving them, a bunch of fluid and then popping the clot or whatever, especially someone that was kind of maintaining barely. So, you want to be sure and be communicating with the physicians if they want you giving lots of fluid, lots of blood, or kind of low volume until they actually get control of the hemorrhage, and then you can give the blood. So I think most of them agree that once they decide to do that, they want to get control of the hemorrhage before we start giving them, filling them back up basically. So you just want to be communicating with the doctors how much fluid and blood they're going to want you to be given. And then the other thing that I just was going to talk about real quick was that 3-O-proline. Like, a lot of times they ask for sutures, and I don't know about sutures, I don't know what they're talking about. So he said basically if they're repairing anything in the heart or the chest, they're probably going to use a 3-O-proline. So it's, they're right over there. So there's 3-O and 4-O basically. So that's kind of good to just have it in your head that, if you give them a 3-O-proline, you're pretty safe that that's going to do the job for what they need. So, they'll say nylon and silk, and sometimes I never know. But anyway, he said 3-O-proline is what they would use for inside the chest. And then, that's it. I don't have any more. That's it. If you guys have any suggestions or comments. There was on YouTube, there's actually a video of a thoracotomy. If you ever want to just YouTube it, we just put in resuscitate thoracotomy. It's a Chinese one. It's from China. But it's just a quick little, video of them doing a thoracotomy. So.